And so the outline of what I'll cover today, first we're going to start off with an overview of some of the clinical features of triple-negative breast cancer. And then we're going to move on and review some of the recent data focusing on platinum chemotherapy drugs for both BRCA mutation carriers as well as sporadic triple-negative breast cancer patients in the neoadjuvant setting. And so just by way of background, triple-negative breast cancer represents a particular challenge in the clinic. This subtype of breast cancer is defined clinically by the lack of hormone receptor expression and also by the lack of overexpression or amplification of the HER2/neu oncogene. Standard treatment for early-stage triple-negative breast cancer today in 2015 consists of combination chemotherapy that is anthracycline and taxane-based. The standard treatment has not changed significantly in over 10 years. Additionally, the selective use and targeting of our available cytotoxics have not been optimized in historical studies, though we are starting to see some changes here, and I'm going to go over that. In addition, germline BRCA mutation status has generally not been reported in clinical trials in triple-negative breast cancer, and I hope to convince you today that this is really important to truly understand results in this disease. In terms of the epidemiology of triple-negative breast cancer, it accounts for about 13% of all breast cancers based on California Cancer Registry data. And interestingly, it does vary by race and ethnicity, with higher frequencies among Black and Hispanic women. This is also a breast cancer type that disproportionately affects the young women with breast cancer, those less than 40 years of age. And in terms of risk of recurrence compared to patients with non-triple-negative breast cancer, those patients with triple-negative breast cancer face an increased risk for early recurrence, which is most prominent in the first 3 years after a breast cancer diagnosis. And if we look at those sites of first distant recurrence, what we see is that in the triple-negative breast cancer, more commonly visceral sites are involved, including lung, brain, and liver, compared to patients with non-triple-negative breast cancers. And certainly we've known for some time there now that most triple-negative breast cancers are basal-like based on gene expression profiling. And this pie chart just shows that among patients with clinically defined triple-negative breast cancer, so patients with ER-negative, PR-negative, and HER2-negative disease, about 75% of them will be basal-like using the PAM50 gene expression profile. A few years ago, a group from Vanderbilt took a little bit of a different strategy, and what they did was analyze gene expression profiles from 21 different breast cancer data sets, and from those identified 587 cases of triple-negative breast cancer that they filtered based on ER, PR, and HER2 mRNA expression. They then took these 587 cases and with hierarchical clustering identified 6 stable triple-negative breast cancer subtypes, each displaying unique gene expression profiles. And those 6 triple-negative breast cancer subtypes are shown here. There are 2 basal-like subtypes, basal-like 1 and basal-like 2, an immunomodulatory triple-negative subtype, mesenchymal and mesenchymal stem-like subtypes, and finally a luminal androgen receptor subtype. And certainly the goal with this work was to try to subset triple-negative breast cancers and potentially use this information to target these different tumors differently in terms of treatment approaches. And while we certainly have learned a lot about the biology of triple-negative breast cancer from gene expression profiling, I would argue that probably the most important insights have really come from the study of cancer genetics. Most hereditary breast and ovarian cancers, of course, are due to germline BRCA1 and BRCA2 mutations. And we know that BRCA-associated breast cancers are compromised in DNA repair. And there's long been noted an association between triple-negative breast cancer and those cancers that arise in patients with germline mutations in either BRCA1 or 2. For example, about 75 to 80% of BRCA1 mutation-associated tumors will be basal-like by either gene expression or immunohistochemistry. And also, if you just look at a large group of patients with triple-negative breast cancer unselected for family history, what you see is that the frequency of BRCA mutations can be up to 20% in this group of patients. And preclinically, we know that basal-like and BRCA-deficient cell lines demonstrate differential chemosensitivity with greater sensitivity to drugs like platinum and gemcitabine and less sensitivity to taxanes. And so breast cancers that arise in BRCA1 and 2 mutation carriers, again, are compromised in homologous recombination DNA repair. And this is due to loss of heterozygosity at BRCA1 or BRCA2 within the tumor. This leads to genomic instability, resulting in a number of deletions and insertions across the genomes of these tumors. HR deficiency has also been implicated in sporadic triple-negative breast cancer, and potential mechanisms here include promoter methylation of the BRCA1 gene, somatic mutation in homologous recombination genes, including somatic mutations in BRCA1 and 2, as well as through other epigenetic mechanisms. And so 20 years on from the initial cloning of BRCA1, certainly the breast cancer susceptibility genes continue to make headlines in the popular press. And despite all of the progress made over the last 20 years, BRCA1 and 2 germline status currently does not factor into systemic therapy decisions, and the potential of individualizing systemic treatment based on germline BRCA status has yet to be realized. We know that PARP inhibitors have single-agent activity in advanced BRCA mutation-associated breast cancer, but so far no drugs have been FDA approved for breast cancer. We recently saw the FDA approval of olaparib for advanced BRCA-associated ovarian cancer, and hopefully soon this will come for patients with advanced BRCA-associated breast cancer. Furthermore, responses to standard chemotherapy drugs and carriers have not been historically well characterized, and there has again been no determination of BRCA status in most of our major therapeutic trials, even in triple-negative breast cancer. And so the current role of BRCA mutation testing in practice has really been confined to guiding screening recommendations, as well as surgical risk-reducing recommendations for patients identified as carriers. But this information currently does not guide our treatment decision. BRCA mutation-associated breast cancer patients continue to be treated according to the same algorithms for the treatment of patients with sporadic breast cancer. And so we're going to move on and talk a little bit about platinum and some of the recent data in both triple-negative patients and in those patients with BRCA mutation-associated breast cancer. But before we get there, I just wanted to go over a couple of cases. So the first case is a 48-year-old premenopausal woman who's diagnosed with a clinical stage 2B invasive ductal carcinoma of her left breast. The tumor is ER negative, PR negative, and HER2 negative. She's tested for BRCA1 and 2 mutations, and no mutation is identified. And so for the question, for her neoadjuvant therapy, you recommend A, dose-dense doxorubicin and cyclophosphamide for 4 cycles, followed by dose-dense paclitaxel for 4 cycles, ACT. B, weekly paclitaxel and every 3 weekly carboplatin for 4 cycles, followed by dose-dense doxorubicin and cyclophosphamide for 4 cycles. C, paclitaxel and carboplatin for 4 cycles, followed by dose-dense doxorubicin cyclophosphamide with this time concurrent bevacizumab. Or D, weekly paclitaxel, liposomal doxorubicin, and carboplatin with concurrent bevacizumab for 18 weeks. So please vote. Okay. So most in the audience go with A, which is our standard, dose-dense AC followed by dose-dense paclitaxel. So we're going to do another one. Okay, here's the case. So this is a case of a 48-year-old woman, again, premenopausal, diagnosed with a stage 2B invasive ductal cancer. It's ER negative, PR negative, and HER2 negative, but this time genetic testing does reveal a deleterious BRCA1 mutation. And so for the question, for neoadjuvant therapy, do you recommend inclusion of a platinum for this patient? A, yes, or B, no. So please vote. Okay, I was expecting this one to be more interesting. So 65% of you would include a platinum and 35% would not. So let's talk about some of the data that might influence these decisions. So cisplatin, of course, has been around for a long time. It was first approved by the FDA back in 1978, and pretty early on it was noted to have activity in patients with advanced breast cancer. The platinum family of drugs, these are platinum salts, and they bind directly to DNA, and this results in the formation of DNA platinum adducts and consequently intra and interstrand DNA crosslinks that can impede cell division. And certainly there's been renewed interest in investigating the role of platinum chemotherapy in breast cancer based on the hypothesis of greater susceptibility of triple negative and BRCA mutation associated breast cancer to DNA damaging chemotherapy drugs. And so back now in 2009, a very interesting small proof of concept study in BRCA1 mutation carriers was reported by a group in Poland. And what they did was look at single agent cisplatin, 75 milligrams per meter squared, given every 21 days for 4 cycles, as neoadjuvant therapy prior to surgery, and they reported a PCR rate of 72%. And so certainly this got a lot of attention at the time because we typically don't see anything close to that in a largely triple negative breast cancer population. And so there was lots of enthusiasm, but it also raised lots of questions about what the response to standard therapy is in patients with BRCA mutations. And so retrospective data from the US, from MD Anderson, suggested that the PCR rates to standard neoadjuvant anthracycline-based treatment was really not that different between BRCA mutation carriers and non-carriers with triple-negative breast cancer, while some more recent data out of Israel suggested that with dose-dense ACT, response rates are really a lot higher, 67 versus 37% in BRCA carriers compared to non-carriers with triple-negative breast cancer. And so where we are now is that we have seen reported 3 randomized phase 2 trials looking at carboplatin as an add-on to standard chemotherapy in patients with unselected triple-negative breast cancer. So the first trial that was reported was from Alba and colleagues from Spain, and they looked at epirubicin and cyclophosphamide followed by docetaxel with or without carboplatin, and observed no difference in PCR rate with the addition of platinum. Subsequently, and more recently, we've seen the results of Gephardt-Sixto from the German breast group, as well as results from CALGB 40603 in the US, showing that the addition of carboplatin to standard chemotherapy did result in an improvement in PCR rates. And so we're going to talk about those studies in a little bit more detail. So the Gephardt-Sixto trial, also known as the GBG66 trial, was a trial of neoadjuvant therapy in 2 cohorts. There was a triple-negative breast cancer cohort of about 315 patients, and there was also a pretty large HER2-positive cohort. And this is the schema for patients in the triple-negative subgroup. All patients received a dose-intense chemotherapy backbone of weekly paclitaxel with weekly doxorubicin, liposomal doxorubicin, and this was given concurrent with bevacizumab in all patients. And then there was a randomization to carboplatin weekly, initially given at an AUC of 2. This was later decreased to AUC of 1.5 due to toxicity. And so patients were randomized to receive carboplatin weekly or not. And all of this therapy was given over a course of 18 weeks prior to surgery. And so these are the main efficacy results from the Gephardt-Sixto trial. You can see on the left that in the overall population, so including the triple negative and the HER2 positive patients, that there was a modest improvement in PCR rates with the addition of carboplatin, but this was not statistically significant. However, if you focus in on the triple-negative breast cancer subset, all of the benefit really appeared to be seen in this group, with about a 16% improvement in the PCR rate when carboplatin was added. And this was highly significant. The PCR rates were about 37% versus 53% in the patients receiving carboplatin. One of the things that was also observed in this trial was that discontinuations were common, and these were primarily due to adverse events. And so if you look at the patients enrolled on the two arms, only about half of the patients who were randomized to receive carboplatin actually were able to complete the full 6 cycles or 18 weeks of treatment. And so if we move and talk about the CALGB 40603 trial, this was also a randomized phase 2 study that took a little bit of a different approach. So this trial employed a 2x2 factorial design. All patients received weekly paclitaxel for 12 weeks prior to dose dense AC for 4 cycles. And the first randomization was to bevacizumab, 10 milligrams per kilogram every 2 weeks for 9 cycles, or not. And then the second randomization was to carboplatin or not, given at an AUC of 6 every 3 weeks for 4 cycles, concurrent with the Taxol only. And so what this slide shows is the PCR rates from this trial in the breast and axilla among patients treated with or without carboplatin on the left and with or without bevacizumab on the right. And so you can see that there was a 13% improvement in PCR rates with the addition of carboplatin, and this was statistically significant. There was also a numerical increase in the PCR rate with the addition of bevacizumab, and this just missed significance at the 0.05 level. And so just to try to summarize where we are, there were 2 recent randomized phase 2 trials looking at carboplatin, and these studies showed an improvement in PCR rate when added to standard chemotherapy. The GuyCam study, of course, was negative, so that was the third of these trials. Gephardt-Sixto and CALGB 40603 showed increases in PCR with carboplatin, but in both of these studies, of course, bevacizumab was also included and potentially confounded those results. We know from the randomized phase 3 Gephardt-Quinto trial that bevacizumab does increase the PCR rate in triple-negative breast cancer patients. And in this prior trial, that improvement was about 11%. And so if we look a little bit closer at the individual arms in the CALGB 40603 trial, what you can see is that the addition of carboplatin to taxane followed by AC improves PCR by about 10%. And then the addition of bevacizumab on top of that results in about another 11% improvement. And so we know that bevacizumab certainly can increase PCR rate by about 10%, but we also know that it doesn't add benefit in the adjuvant treatment of triple-negative breast cancer patients. The phase 3 Beatrice study showed no improvement in disease-free or overall survival with adjuvant bevacizumab in triple-negative breast cancer. So we definitely need to consider the chance that platinum, just like bevacizumab, will not add a disease-free or overall survival benefit in a definitive phase 3 carboplatin triple-negative breast cancer trial. And the additive toxicity, of course, is also a significant concern. And so I think all of this really highlights the importance of biomarkers of platinum response. And certainly there are a number of candidates that have been evaluated, the most obvious one being germline BRCA mutation status. There's also been a study looking at genomic scars due to underlying homologous recombination defects. And finally, some work looking at tumor lymphocytic infiltration. And so as a follow-on to the initial report from Gephardt-Sixto, the GBG investigators did a second presentation where they looked at the presence or absence of BRCA1, BRCA2, RAD50, or RAD51C germline mutations and how this impacted pathologic response. So in this correlative study, germline blood was available for 294 of the 315 patients, and they detected BRCA1 or 2 mutations in 41 patients. There were 3 additional patients that had RAD50 or RAD51C mutations, and then in total about 164 patients were incompletely genotyped. And so considering all the randomized patients with triple-negative breast cancer on this trial, what we can see is that the patients who had a mutation in any of these genes, BRCA1, BRCA2, RAD50, or RAD51C, had a higher rate of PCR compared to non-carriers. And if you look specifically at patients that were non-carriers and separate those out according to those who had family history versus didn't have any family history of breast or ovarian cancer, there was only a minor difference of about 4% in terms of PCR. But what was really interesting is when you break this down according to treatment arm. So looking at the patients who received carboplatin, what we can see on the bottom row here is that those patients who had a germline mutation, again in BRCA1, BRCA2, RAD50, or RAD51C, had about a 23% improvement in PCR with carboplatin. And interestingly, those patients who didn't have a mutation but nonetheless had a family history of breast or ovarian cancer also had about a 27% improvement in PCR when they received carboplatin. And for those patients who lacked risk factors, so no family history and no underlying germline mutation, the benefit to carboplatin was more modest at 11.5%. So I think this observation of carboplatin benefit among those patients with a family history but lacking a germline mutation is really fascinating, and it's potentially due to as yet undiscovered BRCA mutation carriers in the cohort. And so remember that at the time this was presented, over half of the patients had yet to be fully genotyped for BRCA1 and 2. The other possibility is that this could be due to germline mutations in other non-BRCA homologous recombination DNA repair pathway genes, and certainly this study is an excellent opportunity to assess this. And if we consider the landscape of breast cancer genes, we know that many other genes are implicated in familial breast cancer. And like BRCA1 and 2, many of these genes also play a role in homologous recombination. Some of these genes include BRIP1, BARD1, PALB2, ATM, RAD51C, among others. And recent data suggests that in women testing negative for BRCA mutations, multi-gene sequencing can identify an additional 10% of patients with pathogenic germline mutations in some of these other genes. And it has also been suggested that DNA repair targeted therapies could also have a role in these patients with non-BRCA germline HR alterations. And so what we've seen since the summer of 2013 with the Supreme Court case related to the BRCA 1 and 2 patent is that there's now on the market a number of germline multiplex panels that can test for germline alterations in a number of other genes that might be implicated in hereditary cancer predisposition in addition to BRCA1 and 2. And so there are a number of these panels, and certainly we're starting to see more and more patients having these panels performed and starting to see some of these patients with some of these rarer familial mutations. And so while we now certainly have the tools in the clinic to go out and look for some of these other genetic alterations, One of the questions that has come up is whether identifying the cause of homologous recombination deficiency or the consequence of homologous recombination deficiency will ultimately prove the better biomarker. We recently completed PRECOG 105, which is a single-arm study of gemcitabine, carboplatin, and aniparid for patients with triple-negative and BRCA mutation-associated breast cancer. And what we found in the intent-to-treat population, that in all patients, there were 80 total, the PCR rate was 36% to this non-anthracycline and non-taxane regimen. Response rates were higher in patients with BRCA mutations. A major goal of this study, though, was to try and identify biomarkers of response to this platinum-based treatment in patients with sporadic triple-negative breast cancer. And given the clinical potential of DNA-targeted therapeutics, Myriad Genetics has been developing the homologous recombination deficiency, or HRD, assay. The goal of this assay is to detect a genomic HR deficiency scar in a tumor that might be caused by various defects in the HR pathway. This type of assay would then have potential to identify non-BRCA mutation carriers with BRCA-like cancers who might benefit from DNA repair targeted treatment strategies. Early in assay development, the association of genomic patterns of loss of heterozygosity and HR deficiency was assessed in ovarian cancer. And the major finding from this work was that LOH regions of an intermediate size were observed more frequently in tumors with defective BRCA1 or BRCA2. And based on this, the HRD LOH score was derived, and this is a simple count of the number of LOH regions of this intermediate size observed across the tumor genome. And so we assessed the HRD assay in 65 patients that were enrolled onto PRECOG 105. You can see on the left the distribution of HRD LOH scores among responders in blue and non-responders in red. What we found is that mean HRD scores were higher in responders compared to non-responders, and this was true for those patients both with and without a BRCA mutation. This shows the rate of favorable response by HRD alone, BRCA status alone, and their combination. And what this suggests, if you look at the panel on the right, is that the combination might provide a good ability to discriminate responders from non-responders. What we saw was that for those patients with a low HRD score who were also wild type for BRCA 1 or 2, only 8% of them achieved a favorable response to this therapy. On the other hand, those with high HRD score or mutant BRCA 1 or 2, 66% of those patients achieved favorable response. So certainly this type of assay, I think, holds promise for trying to pick out those patients most likely to benefit from a platinum-based approach. Thank you.